record on this. So we are going to start the very interesting part here in the neurosurgery. It's about spinal procedures. And when we learn spinal procedures, first we have to learn this anatomy of this lumbar vertebra that we are having on this picture. Here, I'm just going to go over again. We did this study yesterday, but I'm going to go over it again today. The body of the vertebra that we are seeing here. Let me get a PowerPoint tools, and we can do a lot better than just showing you from that aspect. Here, we are going to show you from the aspect with PowerPoint. The body of this vertebra we talked about yesterday. Now, to access this vertebra, we can go from two different ways. We can come from the anterior part, which is through the abdominal wall into the abdominal cavity. And by going through that, you have to expose through all the intestinal content, stomach, the lower, the small intestine, large intestine, and then mesentery. After we go through them, at the back side of that abdominal cavity, when we reach the posterior aspect of the abdominal cavity, we reach the retroperitoneal wall. That is another part of the peritoneum. We open the peritoneum, then we reach the anterior part right here, the body of the vertebra. This vertebra body that we're showing, it is just a section here for lumbar vertebra. Suppose this is lumbar vertebra number 4, and we have lumbar vertebra 1 through 5. 1, 2, 3, 4, and then 5 would be the L4, L5, and then 5 and S1. S is spinal vertebra. So lumbar vertebra. On top of that, we have thoracic vertebra. 12 of those thoracic vertebra, they are stacked one after another. Then we have cervical vertebra. 7 of those cervical vertebra, they are stacked one after another. Now, through them, there is a foramen. That is the vertebral foramen through which we have this spinal cord that is running up to L1. Starts from the brainstem at the end of the brainstem. As soon as we emerge from the foramen magnum, that is the hole at the base of the brain, then we have the spinal cord, starts from there, and it stops at lumbar 1. Then what happens? From lumbar 1 to lumbar 5, we have this space is occupied by a sac of dura. This dura matter, and there is only a sac of dura left over. And the dura sac has CSF fluid. So if you puncture there, we will find cerebrospinal fluid come out of that dura sac. Now, vertebral foramen, that is where our spinal cord and all the nerve roots, they are emerging out through this area. Now, pedicle are attached, or they're part of this vertebral body. If you think pedicle is coming out like these two areas, they're like a finger-like projection from the vertebra. Pedicle comes and becomes transverse process right here, this blue area, transverse process. Transverse process has a fossa-like structure. Fossa basically is meaning, fossa means a depression. Depression for what? Depression for another bone to meet there. Here we are having this T-shaped bone that is basically called lamina. You have heard about laminectomy. This is where the surgeon takes out the lamina and makes this laminectomy in order to get to the spinal cord structure or the dura sac. This lamina is a T-shaped bone. The tip of the lamina is called spinous process, and you can feel this spinous process when you touch your back. When you are touching your low back or anywhere on your back, you feel these bony prominences. That is the spinous process you are touching. So think about it. You're touching here, then we have few centimeters of this process that goes in, becomes the T, and attaches to the transverse process. This is attached to the transverse process with ligament. The ligament we call is here phlebum ligament, anterior longitudinal ligament, or ligament of phlebum. These ligaments are wrapping around this two bone from the back side or from the front side also. So the ligaments are actually keeping these two bones together. Now, pedicle is a finger-like projection. It's very, very important for fusion surgery. So remember where the pedicles are located, where the transverse process are located, and where lamina articulates actually do not have any articulation space there, but supposed to articulate, or there is a little bit of a joint, saddle-like joint movement. Saddle movement, like you have when you have saddle on your horseback, it moves a little bit. That type of little saddle actions can be, you can find here in between. When you press up on the posterior aspect here, then you feel that it moves a little bit. That movement is because of this fossa and this lamina. So what happens when you stack one vertebral body with another vertebral body without any cushion? They will erode, right? This bone structure will erode away. So that is why naturally we have a cushion, natural cushion. We call that is a disc matter. That disc matter sits right on top, in between all the vertebral body. And normal disc, they stay within this encasing area. Abnormal disc comes out and protrudes, and right here the spinal cord, all the nerve structures are here. That is where the disc material will put compression, means pressure on the this spinal cord matter. If you have pressure here on these nerves, they will send a signal to the spinal cord itself that there is a compression, and the signal will be represented as pain, excruciating pain shooting down the leg using these nerves. These nerves are then sending the impulse as if there is some kind of pinch nerve, or something is electrocution is being done to these nerves. That is very, very bad condition the patient usually experience. So bad, sometimes these patients cannot move. They are crippled 24/7 on a bed. They're confined on a bed for 24/7 until this disc matter, which is causing pressure, is removed, and new graft is placed in between these two bodies. That is the surgery we do on the vertebra. Laminectomy, we take out this lamina, access this area, and fix the disc problem by retracting the spinal cord to a side. We get the disc out of in between the body, and then we go on the other side, clean up the disc material, irrigate it thoroughly, and close it. But in this process, what we lose is this lamina, and this spinous process sometimes is taken out. The whole lamina and the spinous process sometimes is removed. So now let's see what this spinal cord look like. Spinal cord is a cord structure. It's like a white fibrous material, tube-like structure filled with gray matter right here in the center area, and white matter on the periphery. So nerve emerges out of this posterior aspect and anterior aspect on the left side and right side. So nerve is coming out of each section. So for example, if this is a lumbar 1 area of the spinal cord, this nerve root are coming out of this L1. Next one is L2. Next one is L3. Now, as you know, after L1, we only have spinal sac, but nerve still emerges out of there. Now, in L1, what we have, the surrounding this spinal cord, we have the same material, the meninges, dura matter, arachnoid matter, and pia matter that membranes this spinal cord and brain. It's a continuation of that same meninges that circulate that kind of membrane, in membrane, the brain. So accessing the spinal cord from outside, you first encounter the dura matter, the dura layer. Then you encounter this layer, arachnoid matter. After that, you'll find the soft matter or pia matter, which is right against adjacent, really sticky part of the spinal cord. In between dura matter, you'll find blood vessels are emerging, they're running. We call the subdural blood vessels, and they are bringing in nutrients for the and transporting the sugar and oxygen for the brain and spinal cord. Now, reflex action comes because of this nature of the gray matter and white matter's arrangement. When we talk reflex action, we're talking about the action produced by the spinal cord itself without activating the brain. Suppose you are touching fire. As soon as your finger touches the fire, the signal comes from the tip of the finger through this posterior part of this area. Posterior part of the nerves are the sensory nerve. They're bringing senses from the skin from all over the body, including the finger. So tip of the finger will send out the signal, the impulse that will come here, and it will be incorporated into the gray matter through the area, through the structure. Gray matter interprets that as a hot substance and it's causing pain. As soon as that happens, gray matter signals out to the white matter saying that let's activate the motor neuron. These are the motor neuron. They are one that involuntarily moves our body. So the motor neurons are activated to pull the finger away from the fire. And this happens like a cycle. Signal comes in, goes into the gray matter, goes to the white matter signals out to the motor neuron then contracts the muscle of the finger, and by contracting the muscle of the finger, it pulls out the fingertip away from the fire. And that is the reflex action. That is why we don't spend more than few seconds to move our body from fire or substance that is causing pain, maybe a sharp object, without thinking about it. We don't think that we are getting close to a fire. Now we have to move our finger away, but it happens automatically, very, very spontaneous action. And that all of these spontaneous action can be done because of this arrangements of gray matter and the white matter of the spinal cord. If we have some disruption in this area of the nerve or the area of the gray matter and anterior, the white matter, then the reflex is disrupted. Then we touch finger, we burn our finger, then we see it with our eyes, then we feel that pain through our brain, the nerve that goes to the brain, sensory nerves or cranial nerve that comes from the sensory aspect of the brain. By then, our finger is burned. By the time we move it voluntarily, our finger is already burned. So reflex is important for us to survive from any type of danger. That could be fire, that could be chemical substance, that could be a penetrating knife or anything. So reflex is possible because of the arrangement of the spinal cord. So it is important for the surgeon to preserve this action of the spinal cord. So their job is to preserve these nerve roots emerging out through this foramen. And see, there's none of these bone structure, none of the disc matter is causing pressure and disrupting this reflex action of the spinal cord. So that is the procedure we do on spinal cord. Next slide, you will see the procedure that we do on the spinal cord itself. Like I said, laminectomy is one of the procedure, very common, we have to do in order to get to the nerve root or the spinal cord itself. Here we are seeing the spine from back. So from the tip, spinous process, lamina. Top, we have a spinous process and lamina. And in between, there is the ligament that is attaching the spinous process and the lamina to the pedicle and transverse process. So it is covering the, we don't see the underneath yellow structure, which is the spinal cord or the nerve root structure or the dura sac. Now, in order to get to this yellow substance, which is our target area, the spinal cord, nerve roots, or dura sac, what we have to do, we have to cut this lamina, remove this lamina, remove this transverse process. Then we have exposure for the underneath the major structure of the spinal cord or dura sac or the nerve roots. This removal of this area of the lamina, including the spinous process, is called laminectomy. You can do one lamina removal, you can do multiple lamina removal. If we do individual lamina removal, like here, we have a lumbar 5 and S1 area. In between there is a lamina. If we remove that, we will call number L5 laminectomy. Here we have a L4 laminectomy. If we remove this one, it would be L3 laminectomy. Now, if we see a lateral aspect, lateral picture of disc and the vertebra process from lateral, you see here is individual vertebra. In between, there is the disc material that is the cushion absorbing the force in between the vertebra, helping the vertebra to just slightly move a little bit, like satellite joint like motion. Here is a degenerative disc. Because of the aging process, now degenerated disc is ruptured slightly, and the material inside, which is the viscous material, nucleus pulposus. That is the material stays as a at the center of the disc. That is the nucleus pulposus. That is the material actually helps this cushioning, this absorption. When the disc ruptured, then the material, the nucleus pulposus, comes out. Right here, we're seeing a disc material, nucleus pulposus, the bluish color material, came out of there and causing pressure on the space here, the foramen, the vertebra. In this foramen, what we have is the nerve root, the yellow nerve, spinal cord, and the nerve root emerging through it. So if we have nerve root and the spinal cord there, and along that space, if we have herniated disc, that nerve has no place to go. So it becomes compressed and constantly sending out impulses that there is a pain coming from because of this herniation of the disc. Sometimes we have a bulged disc. It's not herniated, but it is bulged and it's doing the same thing. Sometimes we have disc material eroded away and it becomes thin, and the vertebra is now rubbing against each other. And when that happens, over the time, the vertebra has a degenerative arthritis. And later, this will make this angry-looking surface of the vertebra, where the osteophyte causing more pain now because of this bony spar is rubbing against each other and causing pain continuously. This is treated with laminectomy. By removing this lamina, we provide more space for this area. After the lamina is removed, then the surgeon takes a kerosene ronger and smooth these osteophytes away. So he or she will smooth all of these osteophyte and the excessive bulge disc out of that area, and that will become the specimen. This herniated disc, when it is removed, this bulge disc, when it is removed, this will become our specimen, the nucleus pulposus, herniated nucleus pulposa. That would be our specimen. If somebody asks us, what is the specimen that we get after the laminectomy and discectomy surgery? Our number one specimen would be lamina. Then number two specimen would be nucleus pulposus. That is the viscous semi-solid material that we remove from this area. So lateral version, if you see oblique, then you can find this is what is being removed, lamina. So we also have a problem with spinal cord tumor. Now, spinal cord tumors are meningioma mostly. They are actually being produced in the meninges, where mostly in the dura matter and arachnoid matter, in between them, the tumors are produced. They're the excessive growth of the meninges. And when that happens, imagine what's going to happen to this space. It will be really, really compressed. And that needs to be removed. Sometimes the tumor kind of starts at one level and progresses upward or downward to the other adjacent nearby levels. Now, in that case, we have to remove several lamina from several levels of vertebra in order to expose the spinal cord tumor, and then slowly resect the spinal cord tumor away with pituitary rongers or some other means, whatever the surgeon prefers. So laminectomy is done first for treatment of compression fractures, like here we have. Second, disc herniation, like the picture you are seeing here, and spinal cord tumors. In order to get to that spinal cord structure, in order to get to that disc material, laminectomy is done. Now, you're going to say, okay, we remove this bone, now this area is becoming very, very unstable. True. That is why after the laminectomy is done for more than one level, then we put bone graft in this area. After the surgery is done, after the disc is removed, we put bone graft in this area and fuse it using plates and screws. The plates and screws will be then applied to the nearby vertebrae where the lamina and the pedicle are still intact, and they will stabilize, they will use it as a fusion. The joint will be fused together, so it becomes stable again. So this is what the laminectomy procedure and discectomy procedure is all about. Next, we have positioning for laminectomy. Lumbar laminectomy, most of the thoracic laminectomy and posterior cervical laminectomy can be done using this prone positioner, Wilson frame. This Wilson frame will be attached to the operating room table first, and then we will flip the patient after anesthesia onto this Wilson frame using 4 assistants. You need minimum 4 people to position the patient prone on this Wilson frame so that they can operate on the vertebra structure here, from spinal cord all the way up to the posterior aspect of the cervical area, thoracic area, lumbar area, sacral area, and the cervical area. All of these areas, they can work in order to do laminectomy, in order to discectomy, or tumor operation, or any other type of surgery they need for fusion. Or for congenital problem, they have lordosis, scoliosis, and all that. That is the curvature, abnormal curvature of the spine that can be fixed by this position. Other position is supine, when they are trying to work on the cervical area anteriorly. The cervical area, cervical lamina and the vertebra can be accessed using supine anterior position also. Here you are seeing a patient is positioned supine and the neck is exposed. The head is turned away from the surgical side a little bit, and a retractor is exposing the vertebra, cervical vertebra. They do anterior cervical laminectomy, anterior cervical disc with fusion, ACDF. All of these procedures can be done. Now, let's see what type of neurosurgery instruments we require for laminectomy procedures. You've seen in the ENT procedure, we need pituitary rongers and kerosene rongers. Same pituitary and kerosene rongers we use for any neurosurgery. Especially for laminectomy, we need the kerosene rongers. We use retractors like Beckman, Atson. We use retractor like Whitlander, vertebral retractor, Scoville retractor, in order to expose the nerve root. We need nerve root retractors, Atson cerebellar retractor for exposure up to the lamina. We need periosteal elevator, Cobb, Key, this type of periosteal elevator, because we're working on the lamina. That means we have periosteum on top of the lamina. We need to strip that periosteum off. We need dissectors like Penfield and Freer dissector that you have seen in order to dissect those ligament. Remember, the lamina process is attached to each other to the nearby bone like spinous process and the pedicle, the fossa of the spinous process with ligament, longitudinal ligament, anterior, posterior, and phlebum ligament. Those needs to be dissected away. How we do that? We use Penfield and Freer dissector, and then we cut it with pituitary rongers or 15 blade, knife blade, 15 blades with a number 7 knife handle. We use bone curettes to smooth things out. The vertebra sometimes becomes irregular, right? Because of degenerative process, you have seen irregular vertebra. Those corners, those edges needs to be trimmed away, and we use bone curettes to smooth those excessive unnecessary bone growths. So the herniated disc process, what we do, we explain how we make the progress, how we proceed with the removal of herniated disc. Here is the structure that is showing about the phlebum ligament. See the ligament of phlebum, and there's other ligament, anterior and posterior longitudinal ligament, how they're wrapping these bones, keeping these bones together. Without these ligaments, this bone will fall apart. But with the this attachment of this ligament, this bone stays together. Now, when we are removing this aspect, in order to get to this area, the foramen, we have to, when you are cutting this lamina process, we need to cut this ligament also in order to get to it. Otherwise, these ligaments going to hold up this bone process, and we're not going to be able to remove them. And if we cannot remove these lamina, we cannot get to the disc area to remove the herniated disc. So usually midline incision is done on the area of the inflamed back. If you have a lumbar 4 disc problem, herniated disc at the lumbar 4 region of the back, then we make a midline incision, vertical incision of the around the lumbar 4 area and the back. Then we use Bovie to control the bleeding of the skin and subcu. After that, we are reaching those erector spinal muscle, the muscle that runs from the neck all the way down to the sacrum area. It's a long muscle chain. They work. We call it erector spinal muscle. So we kind of spread that erector spinal muscle with elevators, like Cobb elevators, to make room, to make exposure to the underneath bony structure. So after that, we can use self-retaining retractor like Whitlander or Adson to expose that area where we're working. Now we have the bone structure along with the periosteum intact is exposed. Periosteum and the deep paraspinous muscle then are stripped using blunt dissection, using Cobb elevator. Sometimes surgeons use a floppy sponge, like lap sponges or Ratex. They put Ratex with the Cobb elevator and kind of strips off these periosteum and paraspinous muscle off the lamina, the spinous process, lamina, and pedicle area. Now we are deep exposed lamina, exposed the spinous process. We are deep into the bone of the lamina, back side of the vertebra body. There we use a deep blade called Scoville or Beckman-Adson retractor. That gives us exposure to the lamina edge. Now, in order to get to the anatomical location of the lumbar 4, which is our targeted lamina here, we have to use C-arm. So we put a spinal needle and we bring in C-arm fluoroscopy to identify the area that we are working on. If we find our needles are placed on the right level, then we proceed with curette, and we now are trying to remove the ligamentum or the ligament structure, ligamentum flavum, longitudinal ligament. We remove them using number 7 knife handle and 15 blade, and we grasp them with the ligament grasper, sometimes with pituitary ronger. So in this case, now we are stripping off ligament. The bone is now exposed. The lamina is exposed. And we are now seeing the process from the top. Here, we use punch and curette, kerosene rongers, so that we can access the dura. At the level of lumbar 4, we only have dura sac. So underneath the dura sac, we have these nerve roots. They are causing these excruciating pain because of compression of the herniated disc. So in order to get to the disc, which is located in between the vertebral body, we have to retract this dura sac. And how do we do that? We use a special nerve root retractor called LUB. That nerve root retractor is 90-degree angled, and you'll see the picture, to expose the disc space. So this space is now exposed. We again identify the proper disc material and disc space. Then we take a pituitary ronger to remove the disc bite at a time. And this is the intervertebral disc material that we are removing includes nucleus pulposus. That becomes our specimen. We remove it from the tip of the pituitary rhonger and put it in a container as specimen. After the area, the intervertebral space is properly cleaned using pituitary rongers, then we check for more disc material which may be stuck anteriorly. So we tell the anesthesia to pull the head. While pulling the head, what they're doing, they're putting traction on the vertebra. So vertebra is spaced now because of that pull. If there is any extra loose disc material stuck there in between the vertebra, that is exposed now. Because of that moving action of the traction of the vertebra towards the head, that space extends and we can find some hidden disc material. That is done to make sure that we don't leave behind any disc material for a future time. That disc material could become a problem or pinched nerve. Couple of times that traction is done, and then we irrigate that wound with whatever choice of irrigation that we have. Use a lot of cottonoid, neuropathies, and bipolar cautery to cauterize the area in order to stop all the bleeding process. We obtain the perfect hemostasis, no more bleeding. We wait for a few minutes to see if there is any dormant bleeding that can come, and we make sure there is no more bleeding at all, and all the area is cleaned properly. Then we start closing the layers of the ligament, erector-spinal muscle, subq, and the skin. Then we dress the wound and we send out the specimen, the disc material as specimen. So this is the surgery of the laminectomy with discectomy. With this, we can also approach the same area, and we can use some fusion technique. If we think by cutting off the lamina and the pedicle, we are going to create instability for that area, then we can use bone graft or spinal plating and screw system to stabilize the nearby vertebrae. That is, if we are working on lumbar 4, then we can attach lumbar 5 and lumbar 3 by using these plates and screws and bone grafts like a bridge. And those bone grafts and plates and screws within 6 weeks will incorporate and fuse together, and that will provide stability for that joint. Sometimes we may have to remove more than one level of these disc material, lamina material. In that case, fusion is essential. Anytime we are moving more than one level, we need to have a fusion done. So that is also part of the lumbar laminectomy with discectomy and fusion surgery. So we may see schedule like this: lumbar 3, 4, 5 discectomy with laminectomy and fusion with TSRH, TSRH is a plating system that can be used, rod system that can be used. It is the term means it's a company in Texas, Scottish Rite fusion system. So they have a modular plating and screw system which works very efficiently when the multiple levels of vertebra area is exposed and multiple areas of this material is removed with the laminectomy process. So this is what is done for laminectomy and discectomy surgery. Now, I'm going to stop here for your break time, and also pause this recording.